This lecture is going to discuss a new group of drugs called checkpoint inhibitors, or sometimes called immune checkpoint inhibitors. And so when we talk about checkpoint inhibitors, we're referring to specific parts in these cells that basically allows the cells to know who they're dealing with in terms of their cell-cell interactions. And so a classic example, and one that has the most targeted therapies with it, is this PD-1, PDL1 interaction. And so tumor cells typically express PDL1, so this is the ligand, as well as other antigens. And these antigens are typically picked up by the T cell receptor, and so this would be one of your cytotoxic T cells that would theoretically be primed to recognize that this tumor cell is essentially foreign and doesn't belong and should be apoptosed effectively. Well, what tumor cells do is they are cognizant, at least, of this behavior, and so they know that this particular antigen will engage the T cell receptor and will produce a apoptotic effect. So what they do is they upregulate the PDL1 antigen, shown here in blue, and this interacts with the PD-1 receptor, and this is actually a silencing mechanism. And so when these two receptor ligands molecules are engaged, you can see here there's an inhibition of killing of the tumor cells. So this is actually one of the ways in which tumors evade apoptosis, and these are one of the, of course, hallmarks of cancer, and we'll be referring to that throughout these lectures. And so by basically having this particular receptor ligand interaction, the tumor cell saves its life. Okay, so from a pharmacologic standpoint, what we're going to do is we're going to try to disrupt this particular interaction of these two blue receptors so that they don't engage, okay? And we can put molecules either on the ligand side or on the receptor side. It doesn't matter. We can block either of these two molecules from interacting, and if either one of these are blocked, or both of them, then obviously this survival signal is inhibited, and then this particular interaction of this antigen and this T cell receptor complex, this can actually occur, and then this will promote tumor cell death. So we want these two reddish orange receptors to interact, because that will promote tumor cell death, and we want to inhibit these two blue receptors from interacting, and that will assist in tumor cell death, as shown here. Okay, and so this is one of the ways in which tumor cells evade apoptosis, and they continue to grow and proliferate basically unaccounted for. So there's two interactions that have several therapeutic drugs that can alter these interactions. And so one we just talked about is the PD-1, PDL1 interaction. And there's a handful of drugs that can reduce that. And then there's another interaction here, the CTLA4 combining with B7-1 or B7-2. And so this is kind of your classic co-stimulation ligand interaction. And of course, there's a couple of drugs coming through the pipeline, and one that already has FDA approval for this interaction. And so for this lecture, we'll focus on the first two drug classes. They don't really have a name other than the PD-1 inhibitors or the PDL1 inhibitors and the CTLA4 inhibitors. Other potential targets that are coming through the pipeline are listed here. For the simplicity of this lecture, we're not going to get into all of these, but understand if you encounter some of these proteins or these receptors in your readings, there are drugs coming through the pipeline very quickly, and hopefully in the next year or so we will have more drugs to add to this list. Now, PD-1 is an important protein reaction because that particular receptor ligand interaction can be found on T cells, B cells, and NK cells. So there's lots of different hematopoietic cells that can express this, but also cancer cells. And so remember, one of the ways in which cancer cells kind of contribute to burden is that they actually start to kind of behave like hematopoietic cells. They actually take on a hematopoietic-like feature in terms of their ability to move from one anatomic site to another. They can actually move through endothelial cells, they can insert themselves into the bloodstream, and then likewise they can leave the bloodstream and then insert themselves back through a different endothelial cell in a presumably different organ compartment, and then take up residence there. So a lot of these tumor cells do have, I would say, hematopoietic-like behavior, and that's really kind of the analogy in terms of how cancer cells behave like immune cells, especially in the process of wound healing and chemotaxis. So the PD-L1 interaction is important. When these drugs are given, we can inhibit apoptosis of the T cells and kind of make them a little bit more effective at producing a cytotoxic outcome. And so their main cytotoxic outcome are what we would call the classic CD8 T cell effector response. And so when these activated T cells that are CD8 in lineage start to convert to Tregs, they lose that effector function. They lose that ability to instigate or initiate apoptosis of the offending tumor cells, and so we want to prevent that too. So these drugs actually inhibit that process as well. And so there is an interaction here between the tumor cell, which obviously supports or expresses the PD-L1 ligand, the CD8 T cell, which has the PD-1 receptor, as well as the corresponding antigen presenting cell, which has the MHC class 1 interacting with CD8, and then it has the CD80 or CD86 receptor complex acting with CD28 on the CD8 T cell. And so, the interaction of these three cell types, the antigen presenting cell, which of course would be something like a macrophage, with this T cell that has now become activated because of the co-stimulatory ligands that are shown here, as well as its interaction with the tumor cell, all three of these things need to interact in order to have an efficient T cell effector response against the tumor cell. And so that's kind of the key outcome for this group of drugs. And so from a mechanistic standpoint, we want to say that these drugs inhibit the receptor ligand interaction of PD-1 and PD-L1, and by doing so, we're going to promote apoptosis by making sure these two proteins do not bind together. And I don't know if this is necessarily important at this juncture, but obviously if you become an oncologist, it is important to know which one they target. But for the sake of simplicity, we can say that all of these drugs target this interaction. We do have specific inhibitors of PD-1. Pembrolizumab is kind of the first drug in this category. And we'll talk about what that particular drug does. Nivolumab is kind of the second generation drug in that category. We've got inhibitors of PD-L1, and these three are listed here. These are tongue twisters. I'm not even going to bother trying to pronounce these. But the side effect profile is pretty large. You can see dermatologic toxicities, GI and liver toxicities. You can see some hypersensitivity reactions. You can see alterations in bone mineral density and so forth, and some of this can be managed with steroids. You can see adrenal insufficiencies as well as lung problems as well. In terms of pembrolizumab, which I said was kind of the grandfather drug in this category, the indication list for this drug is quite extensive, and so we've got hematologic malignancies as well as solid tumors here on the right. Indications for nivolumab a little bit shorter. These drugs are, or these indications are listed here. Notice a lot of these talk about platinum resistance or platinum refractory. So this particular drug class is kind of used later down the pipeline after the first line therapy has typically been shown to be either non-effective or exhausted, or the patient has probably reached some type of high side effect profile due to probably a dose-limiting toxicity. And so you'll see this type of drug maybe as an adjuvant or an add-on. And then the other drugs in this category are all listed here. The first two are specific for currently non-small cell lung cancer, excuse me, and then avelumab, which is specific for a specific metastatic Merkel cell carcinoma, which is shown here.